Next up is Philip Scott, another of the co-conveners of this meeting, who's going to tell us about his online survey.
Thanks very much, Nick. So this is really to lead us into the first of our workshop discussions about kind of what collectively we're bringing to the party, as it were. So we asked people to fill in a survey before coming along, and fortunately most of you did, not everybody, but we've got a reasonable kind of snapshot of what kind of skills, knowledge, experience are being represented here. Just while we're waiting for the slides, just to add to Jeremy's point about the write-up of this meeting, so I've already emailed out to all the speakers inviting them to contribute a short report. But as Jeremy said, if anybody else has ideas for particular submissions to go into that supplement that we're going to have in the journal, by all means come and have a chat with me and we can see what's possible. So my day job is at the University of Portsmouth as a reader in health informatics. Well, that's half of my day job. I'm actually now also 50% back in the NHS as a digital healthcare architect at Portsmouth Hospital's NHS Trust. So it's actually very nice to be on both sides of the fence and be thinking about stuff and trying to do it as well. Okay, so in analysing the survey, we're just going to look at what sectors and organisations we've got represented, what products and partners people have worked with, level of experience, why we think it's important, concerns perhaps that exist, and there are very many legitimate concerns about this field, our level of enthusiasm, what we can offer, and my subjective assessment of where our strengths lie. So by sector, so the orange bit is arm's length bodies. So we've got about a third of us, it seems, are from arm's length bodies. 22% academic, also 22% from suppliers, and 22% from professionals, so people involved in frontline care in one way or another. And I think we have one regulator represented. And just for the sake of clarification, because people look at organisations differently, I've counted NICE as an arm's length body, not as a regulator, which I hope is right. That's how it seems to me anyway. So who we are, I was thinking we would have lists of attendees to refer to, but I think you'll see in the conversations we've already said there's high representation from NICE, which is fantastic. We're very pleased to have such strong representation. We've got several people from NHS Digital. We've already heard from NHS X. We've got various academic institutions represented, numerous suppliers. So we've got a nice broad mix of organisational representation. All sorts of different products and technologies that we've worked with. So we'll be hearing from speakers later on with reference to some of these things, but again, quite a broad range. So we're not just coming at this from a kind of monolithic product or technology background. Interesting about level of experience. So a small number, none at all. About a quarter, I suppose, have just talked about doing something with this and not get any further than that. Interestingly, no one has explored it and then rejected it. Well, that's encouraging. So hopefully that tells us it's worth pursuing. We've got quite a few who are either exploring it now or soon or are in some pilot phase, but a relatively small number who have routine use, and I think only one who reported mainstream use. So clearly we're at a relatively early stage in the maturity curve. Why we think it's important were just some illustrative quotations, improving health and care delivery. Several people mentioned the foundational importance of this to have a learning healthcare system. We have mention of interoperability, personalised medicine, rapid implementation of evidence, reducing risk, integration with EPRs, improving safety, and one person was honest enough to say not sure. So hopefully we'll all come away with a little bit more informed motivation from today's event. But some legitimate concerns. So safety, again, both a benefit and a risk if we get this wrong, like we heard with Q-risk. Bias, we often hear about this with machine learning. If you train it on a particular data data set, you get a particular answer. Infrastructure, I was talking to somebody earlier about, really how dire so much of the current NHS infrastructure still is, and here we are talking about the very high level uses of computable knowledge. The ethics around this, the privacy, curation and trust in the knowledge. There's a very broad range of issues and concerns we need to reflect on. But fortunately, we're a very keen bunch. So this is the assessment of our level of interest. So only 5 people were kind of in the middle, but the vast majority of us are at the very or extremely interested in this topic, which is why you're all here. So that's great to see. And in terms of then supporting this as an ongoing network and ongoing collaboration, again, pretty high levels of energy demonstrated there, at least in words, and we hope to see that translated into action moving forward. So what can we offer? So again, because we're coming from different backgrounds, we all have different services or facilities we can offer. So we had offers of technical advice, meeting venues, from the academic partners, the opportunity to do student projects, several offers of clinical advice, computational platforms or web space, even secondments, which is quite interesting, as well as help with communication and dissemination of the stuff that we're talking about. So where are our strengths? So this is my subjective assessment looking at the organisations represented in 2 dimensions. So the bottom axis is where we are on the spectrum from data to knowledge. So if you start at the 0 is data, moving along to the right-hand side is knowledge. So Jeremy talked about that distinction. So, and then on the left-hand side, I've split it between those of us who are more at the technical end and those who are more at the human end. So they're rather arbitrary judgments, I accept, but I just wanted some way of representing our relative strengths. And so fortunately, you can see that by far the majority of us are near the knowledge end of the spectrum and are near the human end of the spectrum. So that's encouraging, and it suggests to me we've got the right people in the room. Not saying we don't need the data end and we don't need the technology end, but we are bringing, it seems to me, the right level of emphasis. So, in summary then, we are an excellent mix of stakeholders. We're all different. We're bringing lots of different perspectives and ideas to this. We've got a broad range of experience with different solutions, different providers, different partners. Mostly it's at the early stage, but there is some mature experience that we can draw upon. We do have a good awareness both of the benefits and of the risks that need addressing. And we seem to be quite motivated, and our presence here demonstrates that, and willing to make meaningful contributions. So given all of that, we really want you to make the most of today. We want to hear from you. We want active participation. Now, some of you have known each other for a long time, so one particular point here, don't just talk to your old friends, okay? If we catch you doing that, we'll throw you out. Think about new collaborations. So make a point of talking to people that you perhaps don't know. And also, particularly if you're new to this, don't be afraid to speak up. We don't want groupthink. We don't want everybody just agreeing for the sake of agreeing. We want to hear legitimate challenges. And there really are no stupid questions. This is an emerging field, and if you don't understand an acronym, if you don't understand what somebody's saying, then ask. And we really want this to be a milestone event, the beginning of something. So that's not going to happen by me and Jeremy making it happen. That's going to happen because of all of us offering something. So thank you very much.
So plenty of time for questions. Before we go to our tables. Yes, James.
Thank you. James Freed, CIO from Health Education England. I think I'm one of the people in the more naive category, so this might be a stupid question. In fact, it's 2. I loved what Jeremy was saying about. I can totally conceive of the idea of having a library of knowledge artifacts that people can draw from that are trusted. And you also mentioned that the States is a couple of years ahead of us. Have other people developed libraries of these knowledge artifacts? And if we took the B out of that acronym, have other people tried to do the same outside of the health and care space? And if so, is there anything we can learn from those?
So we'll be hearing from Chuck Friedman later on, who'll be telling us about the progress in the States. I think it's fair to say even there it's still an emerging field. I mean, again, I welcome contradiction on this, but we'll also be hearing later on today from people with a lot of experience in this field in the UK. So we'll hear about how that has developed. I would struggle to name a mature example of that in healthcare. In terms of other industries, honestly, I don't know. To add to that?
I think it's highly likely that in other industries that people are already doing this. I'd be surprised if they weren't. And I think one of the challenges, though, in another industry might be that the knowledge isn't necessarily transferable from one organisation to another, whereas in healthcare globally we have a vast shared knowledge base about people and the diseases and treatments and investigations that are available. But if you look at the insurance industry or you look at the travel industry, the knowledge, well, maybe the travel industry would be an example where there's a lot of knowledge about the world and about airline routes and green ways to travel, etc. So I just don't know the answer to that. It'd be very interesting to investigate, and maybe that could be a strand of work, is to try and harvest lessons and insights and maybe even bring in people from other sectors who have made this kind of approach work. In terms of your question about whether others have tried to assemble large knowledge bases, yes, there have been a whole range of activities over the years, including something called Psych, which was an attempt to essentially build an encyclopedia of the world through an explicit knowledge representation and modelling approach. And that, well, John, you know the guy behind, John Fox. Where are you, John? Do you know a bit about Psych? Psych, yeah. Tell us about Psych and what happened.
Doug Lennett, who founded Psych, which is now a commercial corporation, but it was originally a project funded to model human common sense, and the headlines were, we want to build an encyclopedia of knowledge. It wasn't focused on any particular domain. It was really for this very general knowledge. What do people bring to bear, whether they're clinicians or petroleum engineers or whoever? You have a body of expertise. What do we all have and bring to that? And I think that's been disappointing in some respects over the years. But I think there's been a lot of innovation, and it had a lot of influence in the early years of the field.
And it's been going back 20 years or more. Yeah, more than that. Thanks. But thanks.
Thank you. Good morning. Thank you, Philip. Thank you also to previous speakers, such as Jeremy. I guess the truth is I'm here, so I should say who I am. I'm Deepak Kalra, and I nowadays sit more in a European than a UK footprint. I guess the truth is that I'm here for the M word. And I feel if I was to characterize the morning so far, it's been about computable biomedical knowledge. And when I think about your splash screen of beautiful colored issues, there wasn't really a strong flavor of mobilizing. And I would like to just raise as a question, because I know that this Q&A session is the segue into people sitting around tables. So I wanted to plant, you don't have to respond to this, but plant into the audience a question. What do we mean by mobilizing, and what are the success factors for successful mobilization? Because I don't feel that's yet surfaced, but I think that's a really important barrier to success. Thank you.
Absolutely right, Deepak. And that's the whole reason of today, really, is kind of how do we've had all these various initiatives tried over a number of years, many things that are currently still in flight. How can we get the most out of this collectively? I completely agree. That's why today is ending with some reflection on the day and how we translate it into an action plan, because we absolutely don't want this just to be a talking shop. If that's all it is, then we've all wasted our time.
Just another comment on that, Deepak, and I guess going back to Hadley's talk, standards would certainly help with mobilising knowledge. If it's of high quality as well, then it's likely to become more mobile as people access that. People wanting to build a decision support system in the past have had to not only build the decision support system, the user interface, the interface to the patient record, but also the knowledge base. If only there was a high quality generic knowledge base out there that adhered to global standards, then it would make the task of building these kind of knowledge tools much, much easier. And that would then make that knowledge mobile.
Back to you, Nick.
So any more questions? Okay, well, I guess...
I'm Sue Lacey-Bryant. I lead on Health Library and Knowledge Services in England, for Health Education England. So I just wanted to pick up on the mobilising piece and to take that forward into looking at the learning piece and creating us as a learning organisation. So, for example, I'm talking to Tim Shaw in Australia, who's talking about how you take the care record and what activity happens overnight for a junior doctor in early training years and turning that into mobile learning that arrives in their door the next day through picking up their activity overnight and linking into the guidance and so on. Seems to me we need, mobilising has a lot of elements, and we need to really think about that piece. Otherwise, we risk creating libraries.
Thanks, Sue. Yes, that's a very important point, and I guess that mobilising also implies not only that you have a library, a source of high-quality knowledge that adheres to standards, but also a pull from the people needing the knowledge. So we need to enhance awareness of clinical questions and get young doctors to record their dilemmas that they encounter during as learning needs, and then to be able to give them credit for looking up those learning needs, maybe even formulating a critically appraised topic or something as a result, but perhaps adhering to using the knowledge that's in this knowledge library. Thanks.
And just to add to that, I've been in contact with my local hospital library service to get an inventory of the kind of questions that are being asked, and I think it would be interesting to do that on a larger level when we think about this prioritising knowledge needs. So I found it fascinating to see the kind of questions that the clinicians were asking the librarians to do literature reviews on, some of which really surprised me. But I think that's a fascinating exercise that might be replicated nationally.
Really happy to work on that with you.
Excellent. We'll put it on the action plan.
I think I saw Jonathan's hand up.
Just a simple, naive question. I represent the Patient Carer Forum from the RCP. It's quite overwhelming, and looking at next steps and steering towards this knowledge and then into AI, artificial intelligence, supporting decisions, creating the data. So all of this is quite overwhelming from a patient perspective, and unnerving as well as it may be supportive. It may have its benefits. So I think initially we always need to be quite clear as to what the objectives and what the outcomes are going to be, because at the moment it doesn't seem very clear what the outcomes or what they look like, to allay any patient sort of apprehensions around this.
Yeah, thank you. I think that's a really important point, and I think again it reflects the relative immaturity of where we are with this. That it probably would be quite a struggle to write a lay summary for what we're doing at the moment. It probably could be done, But that's a good challenge. And again, I think that probably ought to be part of our action plan, is how we describe in plain English what it is we're setting out to do. So thank you for that. Still Nicholas.
Hi, another naive question possibly. Are you limiting your scope to professionals? Are you including patients? And particularly have you looked at things like choices and pathways?
We're including patients because we've just heard from one who we've specifically invited. We did have 2 other patient reps invited as well who unfortunately weren't able to be here. So yes, we really want patient involvement because we need to be able to co-design and involve patients in how we describe why we're doing this and how we're doing this, and the whole public trust issue, not just clinicians trusting in the knowledge, but patients trusting in the clinicians trusting in the knowledge, is really important. As to the second point, no, I don't think we have specifically looked at that yet, but it's certain, I'm sure it will come up in our discussions today.
Thanks. There is actually evidence, and some clinicians may be worried about the idea of consulting knowledge systems, particularly in front of the patient, but there have been some studies showing that patients trust clinicians more if they use an online information resource than if they don't, particularly obviously if the patient knows that the clinician is having doubts or is unsure about what exactly to do. And I think that the aim, we haven't really formulated it, but it is about safer, more consistent, more evidence-based care that is sensitive to the patient's needs and wishes. So it would be extraordinary if we excluded patients and carers and friends and family and so on from that. There aren't, I don't think, as many ethical issues around knowledge management as around data management, where there are clearly some big issues around establishing the kind of trade-off between public researcher access to large data sets versus people's individual privacy. Fortunately, we don't end up with those kind of dilemmas, but I'm sure there are other ethical and almost philosophical dilemmas that we would value the advice of society, that the times that we would need to go out to society and consult on whether we're heading in the right direction, whether our values are correct. So yes, we very much see this as a cross-sector, multidisciplinary, including patients in the public activity.